say occasional things like, how now? Hi everyone!
Hi.
Welcome to our Facebook Live session with regards to inpatient antenatal care and induction of labour. We'll start by introducing ourselves. So my name's Bronwyn, I'm the matron for inpatients in maternity.
My name is Kate and I'm the antenatal ward manager.
So my name's Claire, I'm a new consultant midwife trainee, but I worked quite extensively on the antenatal ward prior to this role. So to just start off with, while I log on to Facebook so I can get all your questions up, we'll start off with Kate and we'll just go through to what the day-to-day running on the antenatal ward is like. If you can please all get your questions in so we can start answering them. Hopefully we'll be able to answer most questions, but we might not be able to answer them all, but we'll be able to signpost you to people who can. Some of the questions that you send might not be the correct place for them, but if it's not, don't worry, we will be able to signpost you to who they should be. So, over to Kate. Do you want to tell us what happens on the antenatal ward, which is level 6?
Yeah, so the antenatal ward is based on level 6. Some of you may come up to level 6 already for fetal medicine unit or Silver Star, some DAU scans, those sorts of things, but the main side of the ward is a 21-bedded ward with a 4-bedded induction of labour bay as well up there. Of those, we've got 9 side rooms for appropriate use when clinically indicated, so that people can have a bit of privacy in those ones. In terms of people who come to the antenatal ward, we have people who maybe have had some bleeding, or they've got blood pressure problems, maybe some preeclampsia, or potentially have some abdominal pain that we aren't sure what the cause of that is, sometimes infection. There's lots and lots of different reasons that people come and spend some time with us on level 6, and of course the induction of labour bay is run from there as well. Normally when you first come up to level 6, wherever you are coming from, that midwife will do a handover to the level 6 midwife. They will then ward you to your area. So each bed space has got a bedside cabinet where you can put some of your belongings. It's got one of our beds. It does have a TV that comes out of the wall, which people can buy cards for, but most people tend to watch things on their smartphones or iPads and things like that. It also has a table that can go over your bed as well, that you can sort of eat and drink from, put other personal belongings and things on there. And each of the bed spaces also has a call buzzer, which you can use for routine things, and an emergency buzzer should we need extra help. On the ward itself, there is a water fountain to enable you to get water any time you like, and there is a tea and coffee cart, which again, it's for you and your visitor when you're there to get tea, coffee, hot chocolate, squash. Sometimes our catering team are great, they put biscuits out, little snacks and things for people, and that's available to you 24/7 to enable you to just not have to rely on other people and waiting for people to get things. That's really great for people as well. We also offer 3 meals a day by our great catering team, but we do also have an ad hoc menu which is available again 24/7. If you feel like you're a bit hungry, maybe you've been admitted a little bit later in the evening, or you've missed the meal ordering time, you can order food, hot food and cold food 24/7 from there as well. You just need to speak to your midwife or your support worker about that. In terms of the people that are on the ward, we have 3 midwives on during the day and 3 midwives at night, plus 1 support worker during the day and 1 support worker at night. We also aim to have a ward clerk that's available during the day, and then we've got our housekeeper that's available Monday to Friday, who can help with getting like clean bed sheets and ordering food and things like that. And then we obviously have our doctor team as well. So you will see normally an SHO or a registrar and a consultant overviews the whole of the antenatal ward throughout the day and night as well. So in terms of the general structure of the day, normally breakfast comes around between it's about 7 o'clock in the morning, and then the midwives will take a handover between 7:30 and 8 o'clock ideally. Sometimes if the ward is really busy, that can overrun towards a 8:30 time, but ideally we like to hand over by 8 o'clock. After that, the midwives will come out and they'll check your drugs charts and things just to see when your medications are next due. They'll have a little look at the workload. So each midwife, there's normally 1 midwife that's allocated to the induction women, and then there are 2 midwives that are then allocated to the rest of the ward as well. And then what happens is they'll come round, they'll introduce themselves, see if you've got any immediate questions or concerns that they can answer for you. And then depending on how many weeks pregnant you are, they'll start to do some CTG monitoring on you or listening into baby. And then at 10 o'clock, 2 o'clock and 6 o'clock, and that's both morning and evening, they'll come round and do a drugs round, which is where they'll offer you any routine drugs that you're needing, maybe some pain relief if you're needing some of that. They'll offer you to listen into your baby, just chat with you about anything else you might need, and it just means that you know that someone will come round. That's not to say that if you have any concerns or questions outside of those time frames, you can't alert us to those, and you've got your buzzer and you can ask questions anytime you like, but that's the rough structure of the day. The doctors will normally do their ward rounds in the morning, but then can be contacted throughout the rest of the day as well in case anything changes, like you're needing additional support with things. And then also there is currently myself managing, but come the end of January there will also be Aaron who'll be managing with me, and we try and be available as much throughout the week as we possibly can, ideally definitely Monday to Friday, but we also work weekends as well, so if you've got any questions or concerns you can always ask your midwife to speak to one of us too.
Yeah,
Do you want me
thank
to answer that question?
Yeah,
first?
good question.
We've got a question from Amy who said, how many beds are on the induction ward, and is there any form of induction that would let you go home to wait for things to start?
Sure. So our induction bay is a 4-bedded bay. However, because we do acknowledge that the induction process is quite an intimate process for people, we try not to fill that bay when we're doing our examinations and chatting to you about different concerns and things you may have. So although we can fill up to 4 people in that bay at a time, we try just to have 1 to 2 at a time. And then what will happen is you'll come in and we'll go through the induction process, which I'll chat through in a bit more detail in a bit. And once we've got to an appropriate part of that part of the process for you, we would then move you to a different area in the ward. That might be another bay within the ward. None of our bays are more than 4-bedded bays, or it might be a side room depending on what your clinical picture is and how safe it is for us to put you in a side room and whether we've got them available. We currently do offer Foley's as our method of induction for outpatient use. There are certain guidelines for people that we would offer that to, and those we would offer for you to go home with. So the Foley's induction is, some people know it as a balloon catheter approach, where we insert, it's a very, very bendy sort of pipe, for want of a better word. Soft tube, yes, that's a great term. Which is put into your cervix, and then it's expanded using water to try and place pressure on the cervix, and then that stays in for up to 24 hours. Some people can have those put in but are advised to remain an inpatient in the hospital. For example, if you've had a cesarean section before, or we've got any concerns about you and your baby, or if you are a low risk lady and you're having that, then we would potentially offer you to go home with that in situ as well.
Okay, so OMVP have said there's been a couple of people who are unfortunately unable to watch today, but they've had some questions in their inbox, so we'll just start making our way through those. So the first one is, if you have been induced before, is a subsequent induction faster or different? How does that usually work?
It's a really good question, actually.
Yeah.
It's I wouldn't like to say it's always quicker. I think the general thought process, particularly with subsequent pregnancies and labours, is that generally tends to feel a little bit quicker, but you had to remember that this is not sort of your body going into labour naturally. We are asking it to do something a little bit earlier than maybe it would otherwise want to do it, and therefore it's challenging to know whether the induction process will be quicker. Certainly once women get into labour from the induction process, that tends to be quicker if you've had a baby before, and I would say sort of anecdotally it does tend to feel a little bit quicker, but I wouldn't like to say it's always quicker if you've had a baby before, because it's dependent on the method, how early we're inducing you, what the reason is for the induction, and those sorts of things will help us create individual clinical pictures for you. So it would be great, you could have a chat with your midwife maybe when you next see her about what her thoughts are on this, if you've already got an induction booked, and certainly we can have conversations about those things. I would say overall the labour is definitely still a little bit quicker, but it's quite challenging to say if that's always the case or not. Would you agree?
Yeah, I agree with that. And I think, like you said, it depends on the method of induction that we're using as well, because some women might not need to have the prostaglandin gel if they've had a baby before, so we're already starting from a kind of starting a slightly more advanced point, aren't we? So I think it's very much an individual
Yeah,
kind of.
definitely.
Perfect. So next question: how many sweeps can you have?
That is that's an individual. It's a good question.
How many sweeps do you want?
Again, I feel like we're going to be repeating ourselves a little bit. Don't feel that that's what we are, but again, it's very individual. I think what's really important to remember with pregnancy, labour and things, although we set out guidelines for how we generally feel things would progress, we really do like to take each woman and her history and her current pregnancy into account, what their wishes and thoughts are about how often we can do things. There's not a set maximum number or necessarily minimum number, because people can absolutely choose to decline having sweeps, the same way you can ask to have additional sweeps if that's what you feel like is necessary. And then what we would discuss is the risks and benefits of having additional sort of intervention, for want of a better word. Would you say there's any maximum
No, I
number?
think would we want to kind of give it a certain amount of time before we try another one? So I
Yeah.
think, are we saying sort of 24 to
24
48 hours?
We wouldn't want to be
We
doing them every 12 hours or
No.
something like that.
No, so give it a chance to kind of potentially work
Yeah.
and then speak. But some women, as you may know, but some women might be recommended or might be offered them earlier than 39 weeks. You know, for example, if they have some medical conditions, that
Yeah.
might be something that they discuss with their consultant or with their doctors. So yeah, there isn't a maximum number. It's again individual, individualised. Have a chat with you and see what you prefer and what you
Definitely. But if
what
it's
you're comfortable
something
with.
that you know you're potentially wanting more of, then it's definitely something highlighting to either your obstetric team if you're under an antenatal clinic, or speaking to your community midwife about what feels right to you and what plans and process we can put in place to make sure you're feeling control of that part of your pregnancy as much as possible.
And also, of course, you can decline them.
Of
Because
course,
it's
absolutely.
Not something that
It's
you,
not
that
nothing
you,
is
that you
set in
have to
stone.
have,
Absolutely.
at all.
Perfect. So next question that's been sent into the inbox. Do you have any suggestions for helping to induce labour at home? Any natural induction methods? So funnily enough, I was on the NHS website this morning to see what it said for this. So there's officially there's no.
We can't
We can't
recommend
recommend any ways.
Because there isn't enough evidence to recommend any sort of natural or herbal or other kind of home remedy. I mean, yeah.
It's really tricky.
It's a really difficult question. I think the best thing to do is to try and keep which is obviously really difficult coming towards the end of your pregnancy, as calm as relaxed, to get that natural oxytocin flowing is probably the best, safest way of recommendation for natural home ways. I don't know what you guys
Keeping
think.
active, doing the things you normally do. You don't need to be sort of lying in bed resting lots and lots coming up to that point. So whatever it is that you normally do that keeps you sort of thinking about other things, so you're not focused entirely on that. It's very easy for us to say that, but
So if we think about what we're trying to do is kind of like maximise the oxytocin and the sort of things that would encourage that, perhaps being safe and warm and cosy and
fun
love.
films.
Maybe a little bit of milk, breast stimulation, maybe a little bit of hand expressing, that kind of thing. Practice those skills, but there isn't anything that we could recommend as kind of evidence based that we know would work for you.
Definitely,
Which is, if we could do that, I'm sure we'd be
we'd get
millionaires.
lots of money.
That would be great.
So next is a question from Annabelle. Hi Annabelle, thank you for your question. How does the trust ensure that full risks and benefits are being discussed so that mums can make fully informed decisions on their treatments?
That is a really good question, and it's certainly something that we are constantly improving and working on to make sure, because we do acknowledge that it's such an important part of your journey into becoming mothers, parents, whatever terminology you want to use. We are currently in the process of rewriting our induction of labour leaflet, which is going to be written using the BRAIN acronym, which hopefully some of you have heard of. But if you haven't, just pop it in the comments. I'm happy to go into that in a bit more detail, which is going to look at each method that the Trust offers, looking at the benefits, the risks, and also what the alternatives are, and ensuring that women know that obviously at any point you can always decline an induction if it's not something that you feel is right for you at the time, and making sure you have options available to you. What we are trying to encourage is for this conversation to start quite early in your pregnancy, which sometimes for some women doesn't feel right, and that's absolutely fine. But overall, what we're trying to do is get these conversations to start sort of around the 34, 36 week mark, if not sooner, if you feel it would be appropriate for you. And this enables you to have as much time as possible to do any additional research you would like to do on top of the leaflet that we're currently creating. We will signpost you towards NICE guidelines and any sort of evidence that's available on the intranet as well, to make sure that you can then come back to us and discuss in depth any further points that you'd like to about the things that we offer. What we can also offer, if it's something that feels right to you, is additional appointments with alternative members of the team within the unit to have more in-depth discussions if you have specific things you're particularly concerned about, things that you'd really like to have grounding information and plans put in place for you so that you feel as comfortable and reassured about the process as possible. That is what we're currently aiming to do. We are always open to feedback and anything that people, women like yourselves who are currently pregnant, feel would be best for them. Anything you feel we could implement more of so that you feel more educated and informed about these methods, then please speak to your midwife and they'll get that feedback back to us, speak to the MVP team, and they'll make sure it gets back to us as well, because we know that's not a one-size-fits-all for getting this information out to people, and we want to make sure everyone receives it in the way that feels right to them.
Okay, so our next question is from Alicia. I think there's two questions that are possibly covering about the same thing. So are there birthing pools on level 6 and are they suitable if you've had an induction? And then another one from the inbox from OMVP is, what are the logistics of having an induction, moving between wards and transferring? Can I still labour on the spies if I've had an induction? So I thought we could probably answer those two together.
So let's talk about pools. So there are no pools on level 6. There is a bath and there are showers available and things for kind of, early stage.
I think we're not an intrapartum ward, so we're not a labour ward.
No, so you wouldn't be labouring there.
Yeah.
So there aren't any pools on level 6. We have birthing pools available on the Spires, which is our midwife-led unit, and for some women that may be appropriate and may be offered to women, and in a discussion with you around your kind of risks, what risks we think you might have in your pregnancy. So that is a possibility. We can talk through some of the things that how that might look like. So yeah, unfortunately at the moment we don't have a pool that's working on our delivery suite, and I think that you perhaps already know this.
We will have the plans in place.
There are plans in
very
place.
Soon we will have one.
It's very much in being ordered as we speak, so we're very hopeful that that's going to change soon. So usually we would recommend that any women who are having induction of labour using oxytocin would be on the delivery suite to have their babies, because we can offer them continuous monitoring, and that would be what we would recommend in terms of what we think would be safest for them. So that unfortunately at the moment is a bit of a factor in accessing the pool for women who are having induction and who are having oxytocin as part of that induction. So when I say oxytocin, that means a drip, a hormone drip that's being given to continue contractions. So unfortunately at the moment it isn't possible to offer that continuous monitoring in the pool because we don't have pool. But going forward, we hope that it will change, and we'll be able to offer continuous monitoring to women in the pool on delivery suite when it comes. So, and that's going to be very soon. Do you want to talk about the Spires?
Sure.
Yep.
So in terms of going to the Spires, it absolutely isn't out of the question when you're having an induction. It's something that actually quite a few people, women, have in part of their birth plan, and it's really, really great if you know when your community midwife is placing the referral to us to book your induction, if you make sure she writes on there that you're really hoping for a Spires delivery, then it really helps us sort of like plan and manage your time while you're with us on level 6. So our current guideline says that if you go into labour, and that's labour that's not requiring the oxytocin drip, after either the gel or having your waters broken, or one gel and your water's broken, then you can go up to the Spires. Now that is what our guideline currently states, and what I don't want is women out there who really, really would like the Spires thinking that's absolutely out of the question for them now. There's certainly elements of having individualised conversations that need to occur each time there's something that maybe doesn't necessarily fit into what our guidance says. Our guidance is based on trying to keep both you and baby as safe as we possibly can based on the evidence we have available. But if you feel very, very strongly that the Spires is absolutely where you want to go, and maybe you have 2 gels and your water's breaking, I'm not saying that we're going to necessarily recommend it. It's definitely a conversation that can be had on the day with appropriate people that are available to you. So we do try and get people to labour in their place of choice. And in terms of moving around the building during the induction process, maybe now would be a good time for me to discuss the general skeleton of the induction process, then we can go back to it, because it might cover some of the questions coming up anyway. So once you've got an induction date and time, and I'm going to go through with you what our normal offerings would be, and obviously each time will be dependent on different women's preferences and things like that, so I'm not suggesting this is an absolute set in stone. This is roughly what we would offer. Women would attend the ward at, say for example, 8 o'clock in the morning. They would normally be met by our ward clerk. We would want to weigh you, and that's just to make sure that our drug doses are safe for the weight that you currently are. And then we would bring you down, we'd put some wristbands on, because again that's a safety thing, so that if anything was to happen to you or we need to do anything quickly, we can identify who you are. So we normally put a wristband on each wrist, and we would settle you into the base space where your induction process is going to begin. We normally like to give you a few minutes just to settle in, orientate yourself to the area, go to the toilet. We normally want a sample to dip, a bit like you would in the community setting.
And at that point you'd usually do like a full antenatal check, exactly like the community setting.
Sure, we'd have a feel of your tummy, we'd have a little measure, we'd have a chat with you about how you're feeling, give you the opportunity to raise any concerns, questions, answer anything we can for you at that moment in time. And then we do sort of set of observations on you, sort of blood pressure, your pulse, those sorts of things, just to check that everything is looking great for us to continue the induction process. What we'd also want to offer at this moment in time as well is a lateral flow test and a COVID PCR swab, just to make sure that we put you in the most appropriate place. If, for example, you were to come back as being COVID positive, it would just help us manage your care a little bit differently in terms of how you mingle with other women and things like that on the ward. After that, we would then want to pop you on our CTG monitor. Some of you may not have had a single monitor in your pregnancy, and some of you may have had a few, and that's absolutely fine. And what this does is it runs an analysis on baby, and it takes anywhere from 10 minutes to 60 minutes to give baby a score. I don't say baby a score out of 10, the clinical picture, a score out of 10. And what we ideally want is a 10 out of 10 before we can continue the induction process. If you don't get a 10 out of 10, it's nothing to be worried about. We will have our doctors review your CTG trace, look at what the analysis is saying, why is it not maybe scored you a 10 out of 10 at this point, and then we put in an ongoing plan as to when is going to be safest and the methods that are going to be safest for you. Once we've done all of that, and hopefully you will have had a chat about different induction options prior to this point, because it's quite hard for you to make judgments on how you'd like to proceed if this is the first time you're ever hearing about it. We know sometimes that happens, and we're really sorry when it does, but we do try as much as possible to get you having this information prior to this point. But it'd be at this point then we want to offer you a vaginal examination, and then based off the findings of that is when we would then consider our ongoing processes. So most women would go down having a prostaglandin, so that's a hormone-based gel that's inserted into the vagina. The application looks a bit like an applicator tampon, and the gel sits at the end where the tampon would normally be. We do an examination, and we put the end of that application behind the cervix and insert the gel. After that's been put in, then we do a 30-minute continuing monitor of baby on the CTG, and this is just to make sure that you and baby are well, there's nothing that has potentially happened that's untoward from that, and just to make sure that everything appears to be going in the right direction. Once that has happened, that 30 minutes of monitoring, we'd take you off and we'd have a chat with you about the ongoing plan for the day. So what we currently offer is then a listen into your baby 4 hours after the gel was put in. And during that time, we can come and see you as often or as little as you feel is right for you. So what we don't want to do is bombard you with staff when you're trying to get your oxytocin levels up as high as they can be and as feeling as relaxed as possible. But what we also really don't want is women feeling abandoned, like we've put them in a room and we just don't talk to them again. So we're trying to find that really fine middle ground, and it's really patient sort of women's perspective. So if you know that you're going to want us to come and check in you a little bit often, that's absolutely fine. You just let us know. And if you're like, no, actually I want to just have a bounce and a ball and just chat with my birthing partner, whoever that might be, then what we would then recommend is a listen in of 4 hours afterwards, check everything's okay. it's important to note at this point that babies should still continue to move as normal throughout this entire process. So we do recommend that if prior to us coming back that you get any concerns about baby's movements or anything that's worrying you, just let us know and we'll come back and see you a little bit sooner. At about 6 hours after your first gel went in, so say for example the gel went in at 9 o'clock, by about 3 o'clock in the afternoon, we'll sort of repeat the whole process again. So we'd want to have another check of your tummy, do some observations, pop you back on the monitor, do another vaginal examination, and then if it was felt necessary, then we would give you another Prostin gel. So this is where it gets a little bit tricky, because that second gel is it's dependent on so many different things. So it could be dependent on what your cervix is then doing at that moment in time. If you're already having some tightenings, we have to weigh up the risks and benefits of putting another gel in at that moment in time. And what very often happens is we do this check baby's fine, then we give you a little bit longer to see whether either these tightenings become labour or they die off a little bit. Because what we don't want to do is put hormone into you when you're already tightening a bit and cause you to tighten too much, because babies don't like that very much. So that's what we're trying to avoid there, and it's quite a process of trying to figure out what the safest thing is to do at that moment in time. So sometimes people can feel a little bit disappointed that maybe the second gel doesn't go in bang on that 6 hour mark, and in reality with you it probably 50% of the time doesn't necessarily go in at that 6 hour mark, because women are needing that time for their uteruses and sort of the tightenings to either settle down a little bit or not, and then we continue the process. I think what's also quite key to mention at this point is that if you've had a stretch sweep in the community, that is great, and they may have spoken to you about breaking your waters and things, and that's really, really positive. What we do is we make an assessment on your cervix based on how much it needs to shorten and how much it needs to dilate. And so sometimes, although we could potentially break your waters, you will actually benefit from having a gel. So again, don't be disappointed if you come in and you've been told that you can break your waters, and that will be correct, that midwife will be correct in the community who said that, but sometimes it's actually felt that maybe your cervix is still a little bit firm or it's still a little bit long, and actually it will be to your benefit for your labour to give you a gel just to help your cervix a little bit more before we start the next part of the labour.
And when we assess that, we do have a score that we would use. So it's not kind of just a feeling. We have a score where we kind of do, like Kate says, look at the length, the consistency, the dilatation,
how far back it is, how low the head is down, and
so that would influence the decision. And it's an objective thing, so it means that we can kind of make a plan that's right for you.
Definitely. And what these tightenings are doing from the gel is they're helping to shorten your cervix a little bit. They're helping to make it softer, helping it to make it a little bit stretchier. So sometimes you might find at the next examination you've been quite uncomfortable, but you're maybe 1 centimetre more, or maybe not, but your cervix is a bit shorter, and it's really, really hard not to feel disheartened by that. But actually that progress is really, really important. This induction experience and sort of journey, for want of a better word, to get you into labour is really, really important. That actually it takes some time. Nothing really happens very quickly, but it's all really, really important. It sets you up really well for when labour really does come, if your cervix is softer and shorter. Whereas if you go into that bit and it's quite long and quite firm, your body has to work extra hard to get that bit going. So please don't feel disheartened if you find that after the tightenings you maybe aren't as far along as you had hoped. It doesn't mean your body is not doing it right. It doesn't mean that you're going to labour forever. It just means that your body is doing the things it needs to do before it gets you into that labour point. So after you've had a second gel, we then do the whole process again, the listening in 4 hours later, the examination 6 hours later after the second gel. Again, these are rough time frames, so please don't be alarmed if it might be a little bit longer after that. And what we would be hoping for at that point is that we would be able to break your waters fairly easily. Now this is where sometimes this path becomes a little bit frustrating sometimes for women, because that then becomes very dependent on delivery suite, how many staff there are, how many women are in labour, and sometimes there can be a little bit of a delay getting you downstairs. We will try and keep you informed and updated as possible, but we need to make sure that when we break your waters, we're going to have the staff available to look after you to continue that process, because it keeps you and your baby safe. So if you're wanting an update at any point, just let us know, but sometimes that's where there can be a little bit of a delay, and we do apologise if that happens, but it's to make sure you and your baby are safe the whole time.
And certainly just to say, if you were in labour obviously you would be transferred to delivery suite.
No,
So
we're clarifying that.
we're talking here about, you know, where things haven't quite, you know, where the gel's been working and it's shortened the cervix to where we want it to be, but we're not contracting, we're not needing that midwifery support on delivery suite at this point.
Absolutely.
So anybody that is in labour isn't, you know, we would transfer them to the appropriate place. It might be the spires or it might be delivery suite.
Yeah, and if in amongst this process you go into labour and you start contracting, you require one-to-one care, there's anything that's concerning or anything like that, then we would transfer you to the safest place for you and your baby. And should you be low risk and everything's gone really well, then that might be that we transfer you up to the spires at this point. It might be that we transfer you down to delivery suite at this point. Sorry, we're just logging.
It's stopped. It's alright, we can get back on probably. You're in full flow, that was good. Are we back?
Are we back?
Sorry about that.
I needed to
refresh the screen.
I needed to press a button. So. There we go.
So I'm not sure I got to, but basically, if you were to then be in labour and everything was going well, and the reason we were transferring you is because your labour was cracking on and you were needing that one-to-one care, then that's the time when we would either the spires or delivery suite, depending on what your birth plan is and your birth preferences and those sorts of things. Sometimes we go to do that first examination and actually your cervix is too far along, so to speak, to have a gel
super
super soft,
stretchy.
super stretchy, your head's really low, and therefore giving a gel at that moment in time would not be the safest thing for you and your baby. And at that point, depending on your preference of place of birth, would be dependent on whether we complete the water breaking upstairs on level 6 or whether we wait for a space to become available on delivery suite. Now there is one further. You have to keep going. Because
you are talking
quite a lot.
Well, that's fine. We've got
Sorry,
it's coming up.
I can stop talking if you like, but I think more information is better than nothing else.
It's all very relevant. Great.
So we do have another form of induction of labour. So we've got the stretch and sweeps we spoke a little bit about before, and that can be done in the community setting. And then we've got breaking of the waters, we've got the prostin or hormone gels, and then we also offer currently Foley balloon induction, which we spoke a little bit about at the beginning. In terms of the process for that, it would be the same initially right up until monitoring of the baby, the vaginal examination. Now, it normally has 2 people present for when we put these in, purely because there's lots of bits and pieces that have to be held, and it's just that the midwife who's doing it can focus on just holding that catheter in place whilst the water is being inserted to inflate the balloon. Once that balloon is inflated, then it's the end of the catheter is stuck to the inside of your thigh with a bit of tape, and that's just to make sure that it's held in place. There's a little bit of tension on it because that helps with expanding and dilating the cervix, and then you'll be given sort of a follow-on plan from there. Now, if for example it was felt appropriate for you to then go home and return 24 hours later, then at this point is when we'd be checking that you were well, baby was well, you knew all the relevant numbers to call us if you needed to, and you had no other questions and things, and we'd not let you, that sounds awful, you would be able to go home. If, for example, we felt that you were a slightly higher risk pregnancy, so for example at the moment if you've had a previous caesarean section, then we would advise that you stay in hospital with us just in case you get concerns, there's anything untoward that happens, you're just in the safest place for you and baby, but that can be discussed at the time. The ongoing plan, however, remains the same whether you're an inpatient or whether you've gone home, that it can stay in for up to 24 hours, and either it falls out or we deflate the balloon at 24 hours and remove the Foley balloon. And once that's happened, then we do another examination. Sounds like we examine you a lot, but and then we try and break your waters at that point. Is there anything else you can think about the induction point? Those are the main ones we offer.
So if we're thinking about the point at which you would be we've sort of already touched on that, haven't we? Yeah, about transferring. So it's just a case of
if you're in labour,
you get transferred.
You need one-to-one care for any reason, or there are concerns about you and or baby, then we transfer you to a place of additional observations can be done.
Perfect, thank you. So next question is, how do I decide about having an induction? When will that discussion happen? So I think we touched very slightly on that when we were talking about the risk assessments, didn't we?
Yeah. So these discussions really should be happening in the community with community midwife. If you are midwifery led, assuming that you don't have any consultants involved in your care. So if you're in the antenatal clinic and seeing consultants for your care, you may be offered an induction for clinical reasons, for whatever, it might be medical reasons, blood pressure, diabetes, these sorts of things. And that's a conversation with the obstetric team, and they can talk you through that at your appointments. So midwifery-led women, where we're offering induction for women who, we'll call it post-dates, so women who have prolonged pregnancy. These conversations should be happening in the community with their midwives, and like Kate said, ideally kind of 34, 36 weeks we should be sort of thinking about it, and having those conversations, exactly what it involves, what it would mean for you, what can you do, what are your options in terms of, if you chose not to have an induction, what would happen then. So these are all conversations that we'd encourage you to have with your community midwives, and they would welcome them. Because what we want, as Kate said, is ideally women coming to us on level 6 ready, understanding fully what's being offered, and feeling like they're able to go ahead without lots of concerns, and so it's good. It's really good to have all of that kind of the thinking and the deciding done in advance.
Because we acknowledge it sounds very clinical, and it's sort of, we call it an induction appointment and a date and time and those sorts of things, but we do really acknowledge it's a massive decision to make. It's a really pivotal part of your pregnancy and then ongoing journey, or whatever you would like to call it, into motherhood. And it's not something that should be taken lightly, and we do acknowledge that it's a really challenging decision to make, and it has to be something that feels really right to you as well.
Yeah, and it's not like a sort of it's not a mandatory thing. Like, we really need to get that across, that actually it's an option for you, and we would recommend certain things and timings and things, but it's not that, well, when you get to 40 weeks we book you an induction. It's a discussion, and it's a choice for you to make.
Definitely. Perfect. Right. So I think we've touched on, Alicia, your question of what are the most common successful induction methods. We've touched on the methods that we
So we talked about prostaglandin gels. We talked about the mechanical, so we call them mechanical methods. So at the moment we would offer a Foley's catheter, which is, as Kate's described, as a balloon, or a stretch and sweep, or an artificial rupture of membrane. So that's breaking your waters. So the next question from the inbox is, what are the main implications of having an induction? Will it increase the chance that I would have to have a cesarean section or a medical procedure? Over to Claire. Yeah, so it is more medical. I mean, it's hard to say really, because what are the alternatives? I think also it's very sort of it's individual, as we've already said with all of these things, and it's hard to say for an individual person whether it would lead to a certain place, because there's so many different factors that are going on when someone's in labour, including what's happening with the baby, but we can't deny that it does involve a more medicalised experience. It's certainly if you're going to be on delivery suite with oxytocin, and therefore we know that women who do birth in that environment, they are exposed to more medical intervention than, let's say, if they were having a baby on the Spires and midwifery-led unit, by virtue of the fact that they are on delivery suite. So it's hard to say. I think it's hard to say.
It's really challenging, and I also think it is a more painful way of going into labour, and that has to be acknowledged, because it tends to, whereas some people, when they go into spontaneous labour, it might build up over a number of days. You might have a couple of days where you're tightening a little bit, and then a bit of a break, and it builds up a little bit, and it doesn't necessarily have the same.
So I think there's something about you kind of responding to natural endorphins, and if you're in that, what we're actually doing when we're inducing labour is getting you through that whole process of early labour in a really condensed short space of time.
Absolutely.
So if you are going to go into spontaneous labour, probably you might be kind of niggling a little bit here and there, a few days before you come in, and we don't know how long it would take your cervix to shorten, but what we're expecting when you come in is that it's going to do it in this particular time frame. So suppose there's that to consider, and as Kate said, I think there is this perception that it is more painful, and then therefore maybe women are more likely to request epidurals, and therefore maybe that might, then lead to more interventions. But we have to consider, well, what are the alternatives? What are the alternatives? And we do believe, and there is evidence that prolonged pregnancy is associated with risks of unfortunately stillborn babies over 42 weeks. So there's a balance, isn't there? And it's kind of taking all these things into account. And this is why it's really important to have these conversations.
Absolutely.
We're looking at the guidance from our national bodies, which is nice, and the RCOG have got some information about induction of labour. If you like statistics, I'd recommend looking at that. We're actually going to be introducing a decision-making tool soon for community midwives to help. It's actually to help these conversations in the community with more detailed information about, what are your chances of this outcome and this outcome and this outcome at different weeks gestation. So we hope that will help with these conversations, because they're not easy, and of course we can't say what will your risk be as an individual, and that's part of the challenge of I suppose medicine, really.
It's really hard. There's a lot of grey areas in maternity, and it's quite hard for us to complete studies into it, because obviously it would be quite unethical to say we're going to do this to some people and see what happens and not to others. So a lot of ours is based on sort of retrospective observations and things. Obviously we don't want any poor outcomes at all, so we do everything that we recommend is based on trying to keep you and your baby as safe as possible, but we do also acknowledge that it's such an individual time, and everyone's body will labour differently, everyone's babies will grow differently, it's so hard to create a blanket
one size fits all
for everybody, which is why these discussions are so key, to enable your care providers, your midwives, your doctors, who know your background and know where you are at the moment, make these choices with you.
So thank you for your comment, Annabelle. I'm sorry if these discussions weren't had with you whilst you were
really
pregnant, but I think this is a good time for us to discuss how the booking process works.
Absolutely.
So that people can understand what happens with regards to when you're getting up to your due dates, how those referrals are made.
Yeah, definitely. So what normally happens is that your midwife or your obstetrician, whomever it is that's making that referral, they should have asked you before making that referral, so that you are aware that it's being put in for you, and they should also talk to you about why they're putting the referral for an induction in as well. What that happens is then the induction midwife, either the day one or the night one, there's a big pool on our electronic system which all the inductions come into, and then we print them all off. We look at the reason for induction, how many weeks the doctor or midwife is recommending that you are when the induction process begins, and that's quite key to know. There is sort of often there's a time span. So for example, our post dates induction time frame would be between 41 and 41 plus 3 is when we would recommend. So it may well be that you get booked in for 41 plus 3 or 41 plus 1, and that's why there's sometimes a slight change maybe in how many weeks you are. So they come into the pool, they're printed off, and then we have a booking sort of system spreadsheet. We look for the ideal date for yourself and see if there is a slot available. At the moment we book 8 women for an induction each day. We normally try and do 4 women who've had babies before, book them in for the morning sort of time, and then 4 women who it's their first babies are booked in for the afternoon time. So the slots as they currently stand are 6 a.m, 8 a.m, 10 a.m and 12 p.m, and then 4 p.m, 6 p.m, 8 p.m and 10 p.m. There's a chance that over this upcoming month, because we're constantly reviewing our processes, that it might change by half an hour here or there, but that's the rough structure. And what that enables the induction midwife to do, because she will care for all of you throughout your time period she's on shift, as will the next one, is to stagger you slightly, to enable her to give you that period of time one-to-one when she needs to, whereas if we bring you all in at the same time, then there will be delays and it will be frustrating for everybody. But those are the rough timelines that we set out. So she'll go to the day on the spreadsheet when it's been advised that your induction is booked in for, see if there's a slot. If there isn't a slot, then they look for one day either side, depending on what your obstetrician or midwife has recommended, or also considering what you may have said to your midwife. So it may well be that you've said, I want to go to 41+3, and we will do everything in our power to try and get you a slot as close to the date that you are hoping for, within what is clinically safe and recommended to do so as well. So once that's happened, then the pile of referrals, so we probably book 30 to 50 inductions a day coming through the pool. So then these will then go to our ward clerk, and our ward clerk will give you a call and tell you the date and time that you have been booked in for. Sometimes it will come through as like an unknown number, or a number you've not got signed into your phone. So if you know you've got an induction referral put in, it's worth keeping an eye out for these calls. We don't very often leave voicemail messages for confidentiality reasons, or if we do, it will be sort of a very broad message, vague message with a number to call back on. But most often what we'll do is call you each day, and if we can't get hold of you, we'll send a message to your community midwife to try and get hold of you in a different way to tell you what your date and time of your induction is. So it's worth noting that it's a ward clerk that calls them out, because they can't answer any clinical questions for you. So if you have any clinical concerns about the date and time you've been given, you will be signposted to go back to your community midwife. If for whatever reason we currently have a workload that allows us to take the call back and call you back ourselves, we'll absolutely endeavour to do that as much as possible. But sometimes when we're providing care on the ward, you end up waiting quite a long time for us, and it's better for us to get you back to your community midwife to have those conversations about that. So that's roughly how it works. So normally you will receive a phone call with a date and time, unless it's for sort of March, April, quite a few months away, within a couple of days of your referral going in from whomever has referred you in to the unit. What's also worth noting is, as it stands at the moment, we don't send texts, emails or letters with follow-up of just confirming the date and time. So we will often say to you, have you got pen and paper, or have you written this down somewhere? Make a note of it, because that's kind of the call that you'll get to book it in. It is a process that we're working on, and it's a process we're hoping we will get a little bit better, because we know that's not always ideal for people, but as it stands, it's worth making a note of the date and time when we call you, because you won't get a follow-up message, so to speak.
Perfect. We've got about 10-15 minutes left, everyone, so get any of the questions that you've got left in. So I thought we could talk about forms of analgesia that we've got on the ward, so pain relief that we can have whilst you're going through the induction labour process if you need it.
I was going to say, I love a heat pack, which probably is not, the best. Well, so we do have that. We can offer lots of
non-medical based ones, so we can talk about chat, and then we can talk about the medicine based ones too.
So I mean, it's that, isn't it? So heat pack really useful.
Balls.
We've got balls for mobilisation that can really help with sort of the sort of cramping, back pain, and mobilising. And by the way, we didn't say this, but it's sort of implied that you, whilst you're up there, if you are waiting for that in that 6-hour period, you are perfectly free to roam, to wander. We've got, obviously maybe in winter not so much, but we do have kind of outdoor space that you can go and eat outside, and just sort
of got quite a big day space area at the end of the ward as
well.
So
encouraging kind of mobilisation and being active will help. But also, heat packs, as I said earlier, there is a shower and a bath on the ward as well, so if people wanted to use that, they could.
We do some aromatherapy. What we can't use on the wards is diffusers, just because there is some aromatherapies that aren't safe for people early on in their pregnancy. So there are certain times when we unfortunately couldn't offer aromatherapy, but if it's safe for us to do so, we do have some sort of small amounts of aromatherapy that can be given as well to help people feel calm and relaxed. You can play music. If you've got a speaker at home, bring it in with you. That's a really good thing to have. So you can play, if you've been hypnobirthing, you can play those tracks, or if you certain music you like, or you can play those, or if you want to watch films or whatever, those sorts of things. Although they're not necessarily like heat packs. Well, if you have a good laugh in labour,
distraction. I do. Laughing is very important.
And TENS machines can be really good at this point. We don't keep them as stock on the ward, so you do need to bring that in with you if that's something you're considering. But during this phase of your labour, TENS can be really good at helping help you cope and keeping you active.
Injections on board?
We can do those. So
So that was just a motto, but sterile water injections.
So we do offer. So what it is we. I'm trying to describe it without it sounding really awful. We, for those women who've got significant back pain during this part of labour, so it is really for back pain, not other forms of like abdominal pain, so to speak. We can put. It's a very, very small needle, and it goes just under the surface of the skin in 4 points on your back, just around the lower base of your back, and we put a little like lip of water under the skin,
And
for
you
want of
have
a better word.
You have 2 people to do it, so it's not like 4 individual injections. 2 people do
So
two
do
at
2
the
at the
same
top
time.
and 2 at the bottom, and we try and do it during a contraction, so that you've got other things that are distracting you, because they are quite painful to have them put in, but the pain is very quick, very short lasting, and then it's supposed to help with sort of a distraction process and help relieve that back pain, and it has really, really good.
Yeah, good. Some good evidence.
outcomes.
Yeah,
Yeah,
so
really
women
good.
women report that they have like a lot. Yeah,
Yeah.
effect on.
And then in terms of medical-based
Mm.
pain relief, we have paracetamol and dihydrocodeine, which is sort of like the codeine family, and then we also can offer oral morph, which is literally oral morphine, which you just drink. So those are the 3 main ones that we would offer up there. Once you've sort of maxed out on those ones, and all the ones that Claire has spoken about, and you're still feeling that you're not comfortable, you're definitely in need of some additional pain relief, it would then be a conversation about transferring you to a different area. We don't keep gas and air on the ward, so we have 1 tank, but that tank is to for women who are having vaginal examinations who feel that they need something for that moment of time, but we do not offer gas and air during the early labour stages upstairs, because if you're needing gas and air, you're probably needing more care and input than we can offer you upstairs on level 6. So therefore, at that point, we would be wanting to transfer you to an alternative place to continue your labour care at that time.
Perfect. Annabelle, thank you for your question about how to get your notes. There is an address you can send it to. If you can email I'm not sure the best way to do this, but if you email the OMVP, and then they can get in touch with me and I can forward that address onto you, just because I don't know it off the top of my head, that you can send a request to, and then we can get those notes. I think there may be a small cost, but we can sort that out for you. So we've got 10 minutes left. So this morning, in preparation for this, I walked around the building and spoke to all different midwives from the antenatal ward and different areas to get their top bits of advice for what to prepare for induction of labour. So staff have said to bring something to be entertained by. So as been said before, it can be quite a long process, especially if you're thinking about the hours that you might be waiting between inductions while we're giving the prostate gel time to work. So an iPad, a book,
Speakers,
music, any things like that, things that can keep you
puzzles.
entertained. And as Kate has said before, this is an induction process, and this is the start of the birthing journey. It's a really exciting time, and I think it's a really good mindset to come in that this is a journey. It's not just an appointment you're turning up for. So bring things that can help you and keep you entertained along
Uno,
that journey.
lots of women bring Uno and cards.
Card games,
bananagrams.
Absolutely.
phone chargers and things like that you're going to need to, or battery packs to be able to charge them up. But I think that's a big one. And the main thing is when you move your bed spaces to a different area, make sure you take that with you.
Yes. Maybe even write your name on it, or like a sticker with your name on it, because it's the thing that people leave behind the most. And then we're trying to find out who it belongs to, and there are a number of people it could be. So yeah, worth doing.
We do have Wi-Fi.
We do have
Wi-Fi.
So
you can do anything,
Netflix,
Netflix,
Amazon
whatever.
Prime.
Yeah.
So you just swipe your thing, or just think,
Just
I don't
in
want it
case
to disappear
yeah,
again.
of course.
So someone said be open to pain relief, and I think that's a really important one. I think, as Kate said and Clara have said, the induction of labour process is different than your body going into labour by itself, and I think so just be aware that there are the different pain relief methods out there, and don't keep your mind open to what's out there and what you can use.
And on that note, I think quite often women will come in and say, "Oh, I'm not going to have paracetamol or dihydrocodeine because I don't want them to go away and to stop the labour process." Taking those is not going to stop. It's not going to stop labour. If for whatever reason the contractions die down a little bit or become slightly easier, it's your body's way of saying now's the time to rest, and you should be resting. If they die away, it's not going to stop labour. You do not need to not take them because you think labour won't happen. It will happen regardless of those sorts of pain relief.
Someone said get a good night rest before.
Yes.
If you can, if the nerves and excitement will allow you to. And then other ones were food based, so make sure you bring lots of good snacks. As Kate has said before, we do have an ad hoc menu, and we've got food service during the day. We do have Marks and Spencer's and WH Smith,
And Pret.
a Pret, a Subway now. Lots of different things.
But you might
available
find
in the
once
hospital.
once you get into the laboury sort of bits of it, you're not wanting full
No.
meals, you're
Yeah.
not wanting to eat heavy stuff. So just snacks that are really easy and little, just to eat here and there, whatever you feel like. There's no snack that's particularly
Yeah, and sometimes
Great.
women come and say, "Oh, can I eat?" And it's
yeah.
like,
You
no, you
absolutely can eat,
to
definitely.
to your own appetite. One thing I would recommend, I don't know if it's on your list.
yeah.
Go on, tell me what's on.
No, that just needs to be
Flat
nice onto
Lucozade,
good
that's what I was gonna
nutrition.
say.
So
Oh, good
making
nutrition.
sure you've had a
Okay.
good meal. So in the running up to, you've got an induction process, make sure you're eating well, eating healthy, getting all those nutrients in, so you've got that energy for the process.
And flat Lucozade is really worth having. So if you don't want to eat, not with the
But the
bubbles.
sports brands are available.
Sorry, yeah, we're not sponsored by Lucozade. But it's all I can think of. Any isotonic electrolyte sort of drink. Try not to get the bubbles, because the bubbles will just make you feel a bit sick more than anything else. And that can be great if really you don't fancy eating anything, but it will keep you well hydrated. And keeping your body hydrated means it will labour better.
Before we move on to Liz's question, Claire, what were you going to say before
Yes,
I rudely interrupted?
Yeah, I was
Your
going to
top
say
tip
I would
advice.
absolutely recommend having a nice pillowy eye mask because
Yeah, that's a good one.
because it doesn't get super dark on the ward.
It doesn't. It's
And
true.
actually, you might feel like napping during the day. And I think that having a really nice kind of not one that's really tight around you, but just a nice pillowy one
Yeah.
will just give you a face a little bit of comfort and will
Yes.
help you just to
And
relax.
on that, you can wear whatever you want for an induction. Lots of women ask
yeah.
what they should wear.
Yeah.
There is no right or wrong
Whatever you
thing
feel
to wear.
comfortable
Whatever you
in.
feel. I mean, I probably wouldn't wear the tightest jeans you own, because that might be quite uncomfortable. But there is no right. You don't have to wear a nightgown. You don't have to wear a hospital gown. You can literally wear anything you like, but make sure you have footwear. We don't advise you walking around the ward or anywhere in the hospital in socks or barefoot, because although we do our best to make sure it's clean and tidy on the floor, it's just safer for you to make sure there is something on your feet.
So Liz has said, "Hi all, may I inquire regarding for first-time mothers, if waters breaks, what info to share regarding immediate induction
Very
should one
good
wishes?"
question, Liz.
Mm.
Do you want to answer that, and then we'll get to
Yeah.
the next one?
Yeah.
So we have recently changed our guidance regarding this, probably in the last 2 months, maybe, would you say, maybe a bit longer. If you're a first-time mother and your waters break, and you've had a conversation with a midwife or a doctor about the risks and benefits of waiting to see if labour establishes versus sort of what we call active management. We don't like to use the term immediate, because I think that makes people think it's going to happen straight away, whereas what it is actively managing your labour. If you chose to go for the active management, you were within the first 12 to 18 hours of your waters breaking, and you were well and you weren't really tightening very much, then we could offer you to have a gel, like I spoke about earlier on in the video. We would only recommend one, because once your water's broken, there is that slightly increased risk of infection, so we would offer you one and then continue the process after that, and that is an option available to you. And it's definitely worth having a chat with your midwife when you phone up to say your waters might have broken. After the 18-hour mark, it is not recommended anymore, because our guidance would say really at that point we want to start getting labour going, not quicker, but in a what's the word I'm looking for?
More immediate,
A more
timely.
more timely fashion. So we would look to be going more towards potentially breaking any waters that are still in the front if there are any, and starting the hormone drip, whereas before that it was deemed safer to offer that as an option if you're a first time mum.
And Vic has just said about practicing and learning hand expressing might help. So I think that's with regards to getting
Things
labour
going. Yeah, we did mention that
earlier.
earlier.
Yeah, I
that's
think that's
something
just, we
worth
said
chatting about.
there's guidance of kind of when we can start doing the hand expressing, and obviously
yes.
we don't want it started too
Too
soon
early,
if
yeah,
baby's
absolutely.
not ready to come yet. So, but yeah, that is definitely a great thing to do when you're at that stage, when you're in the hospital waiting for your induction of labour at home, and during those later parts of your pregnancy to try and get that induction going.
Definitely.
Perfect. So we'll just go over any wise words of wisdom that you both want to add.
Your baby will come. That's all I would say. Is once the induction process starts, it might feel like it's forever, and it might feel really laborious, literally, and it takes a long time. But babies will your baby will come, like it will happen. Just be patient and be kind to yourself, because it's a process, and we really recognise that it's quite an intensive process. There's a lot of emotion that goes into it. It can feel really disheartening at points, and it can also feel really overwhelming at points, and we know all of that. And be kind to yourself and give yourself the space that you need to be able to go through the induction process.
And yeah, I think as well, it's like really thinking about it as your birthing story as well as part of that, and thinking about these last few hours. I mean, I know it might feel like a really long time when it's happening, and it is, but these are the last few hours that you're actually going to be not pregnant. But pregnant with this baby and not their parent, and so you can really like try and enjoy them as much as you can, and think about anticipating the baby and have a bit of excitement like Mum and stuff before.
Perfect. Well, thank you all for joining us. It's been quite an
It's
enjoyable
lunchtime.
session. Yeah, lunchtime. Thank you, everyone, and we'll see you again soon.
Thank you.
Bye.
Down there.
Oh yeah.